So a very warm welcome to today's second session of the Joint Initiative Council Open Forum on quality labeling of digital tools. My name is Andreas Klingler. I'm the current chair of the Joint Initiative Council, and I'm also working for Siemens Healthineers. First, a few words about the Joint Initiative Council. Waiting for the slides. Great. Oh. Next slide. What is the JIC? The JIC was established in 2007 by a couple of SDOs which came together to build a collaborative framework for health informatics standards, with the goal to foster the collaboration between the SDOs and the clinical communities and enable the digital transformation and based on information interoperability. And essentially then with overall supporting high quality health services to individuals, the communities and the overall populations. Today, the JIC has 10 members. You see them here on the slide, all the well-known standard development organizations in the e-health arena. The latest addition has been ITU, just new on that slide here. And we are also looking forward at the moment of having a couple of other organizations to join the JIC. What is today's Open Forum about? Many thousand health and wellness apps are in existence nowadays. The most popular ones of these are having millions of downloads in the app stores. Some of these apps fall under the medical device regulations. Most, however, do not. How do users, many of them people with health conditions, know which of these apps are safe, reliable, and effective? How do healthcare providers know which of these apps they can recommend to their patients? And which apps data, which is shown to them by their patients, they can trust? How do payers know which of these apps they can reimburse? Correspondingly, many countries have started to set up own certification programs for health apps. A prominent example are the DIGAs in my own country, Germany. However, every country or region defining own quality criteria for these certification programs, of course, leads to a fragmentation of the market, the inability to benefit from economies of scale, and thus a reduction in availability of apps which effectively address health issues for people in need. And in general, that's just a lot of confusion then in the market. So standards can help to avoid this in two levels. An international standard which sets a baseline for quality labels of apps, guides regulators in defining certification schemes, allows reuse of certifications, and establishes a global market for developers of these apps. This is what ISO 82304-2 is about, and we will hear more about this later in this open forum. Additionally, technical standards like the ones from the SDOs represented in the JIC help developers to create high-quality apps. In the panel today, we will hear from representatives of GIP members, SDOs, how these standards contribute to this goal individually, as well as through the JIC facilitated collaboration among the SDOs. Next slide. Some logistics. We will be able to take questions after the panel. So please use the Zoom Q&A facility to post your questions or also general comments to the presenters, so we can pick them up then after the panel discussion and answer them for you. Next slide. Yeah, there was still another slide I'm missing now. General logistics, all participants are on mute. And as I said, you will be able to post questions through the Q&A facility. So the agenda of today is, well, I'm very delighted in the session today have Steve Posnack, a Deputy National Coordinator of the ONC, as the first presenter, who will share for the United States. Okay, I'm just confused with my notes. So Steve will share or give some insights why this is important in the view of the United States in this second section of the Open Forum. So thanks, Steve, for being with us. But before handing over to Steve, quickly introduce the other speakers. Robert Stegwee, representing CEN TC 251, will give an insight how this standard came about. Following him, Charlie McKay, also from CEN TC 251, will give some details what actually is in ISO TS 82304-2. And then we will move on to the panel discussion, where representatives from HL7, GS1, and IHE will present their own contribution, or their SDO's contribution in this arena. And then afterwards, we will move into answering of the questions you have been posting in the meantime. Last word from me. To stay up to date about JIC, please follow us on Twitter and LinkedIn. And now handing over to you, Steve.
All right, thanks very much. And I appreciate the invitation from the JIC to address you all today. As was noted, I'm going to do some introductory remarks, really get the conversation started, give you a bit of context that is the United States, for those of you that may not be familiar, and we can go to the next slide. Briefly, I wanted to let you know about our office. The United States obviously is a large economy, large federal government agencies. My office is a part of the United States Department of Health and Human Services, so similar to ministries of health in other countries. We were created in 2004 and have assumed other responsibilities vis-a-vis some legislation from our Congress over the better part of the past decade or so. You can go to the next slide. When you think about the healthcare infrastructure in the United States, you know, for those of you that live or work in different economies, we have a very diverse and decentralized approach to our digital health infrastructure. There is obviously a certain element of federal government components that are part of it, but also our U.S. states and many different layers of policy and regulatory governance that are put in place as well. And then to add to that complexity, just the market in general in terms of tens of thousands of healthcare providers, both from the hospital and all sorts of care continuum spectrum. We have a number of different software developers, both in our hospital and ambulatory space. And then we also have a lot of network connectivity as well from a digital health infrastructure too. So you merge all of that together with the significant role that our private sector plays, and you've got very different you know, approaches for how healthcare is delivered, how insurance is paid for and covered, how innovation is financed and supported throughout our ecosystem, as well as how direct-to-consumer and you know, business-to-consumer types of initiatives and opportunities that exist. So let's go to the next slide. Briefly about my office real quickly and what we do and how that may be relevant to the quality labeling discussion in general. You may be familiar with other agencies that are part of my department as a whole, like FDA. They may play a role in this space, you know, depending on the type of scope and context involved. But for my office, we specifically focus on kind of three key activities, being standards development and supporting standards related activities. We administer a certification program for health IT, largely focused on electronic health record software capabilities at this stage. And then when it comes to electronic health information exchange and interoperability, that is, again, another key factor of work and action that my office is involved in. And then we have a large role as a coordination-focused office in connecting with our federal agency partners that may also have responsibilities and authorities in this space, as well as with our other colleagues out in the field. You can go to the next slide. One thing I wanted to show in terms of just why the quality labeling concept may be more and more important over time is to give you a sense of electronic health records adoption. And so you may be familiar with what was called the Meaningful Use Program, in quotes, that started right at the beginning of the Obama administration in 2009. And you can see the rapid growth as a result of the incentives that the United States put forward for electronic health record adoption. And so what that means now, there's lots of digital data that's available in these health IT systems. And so that's going to help power and create opportunities for digital technologies and digital tools. And that's where, again, I think, the quality labeling concept is going to become increasingly more important, both for context and understanding of how market segments are going to evolve. I can go to the next slide, please. I also wanted to give you a sense of citizen engagement or individual engagement in the US. And we have a number of surveys that we do, and they run on their different cycles. So as much as we would love to have real-time data, the best we've got is from our 2020 survey that was recently analyzed in the past year or so. And we start to see steady growth in terms of the sources having digital data available to them, and then making that data accessible to individuals vis-a-vis a number of different ways. This one happened to be a question that asked about how clinicians offer access to patient portals, and then the kind of proportion of access that's occurred. And you can see in the pie chart to the right, you've got accessing via computer, you have accessing via apps, and we expect to see those things change over time as well. And so if you go to the next slide, kind of gives you a sense of the health apps and mobile devices and that are used by individuals in the United States. Many well saturated in terms of the market that have a mobile device. It looks like about 50% have a mobile device with a health app on it, and that's a wide spectrum. For those of you that are familiar with the app space, it's very big. And then you can see from the question that was asked, how many of those people used a health app in the past year. And that was actually quite high from my perspective, having downloaded some of them myself. And then, you leave them on your phone until you uninstall them. And you're like, why did I download this in the first place? But you've got an activated, proportion of the population that has a mobile device that are using health apps. And how do they know, the efficacy or the efficiency or, the capabilities that those apps are performing are going to be up to both, industry standards as well as in some cases, the standards that FDA and other regulators in the space may want to keep in mind. Let's go to the next slide. The one other thing that my staff has looked into are apps that integrate with what we, our technology that we have a regulatory responsibility to certify. So we call it Certified Health IT. There's a paper that they published through JAMIA, if you're familiar with that journal publication. And they just kind of looked at the various different app stores that certain health IT developers make available and categorize them roughly into those 5 columns that you see there. So you see a wide spectrum again. I wanted to give you some context and portray both the quality labeling concept for individual business to consumer type uses, as well as for clinical uses among health professionals. And again, the diversity in different types of applications or software services that are now being developed. So let's move on to the next slide. To really be the wrap up here for me, things to keep in mind. We've had over the better part of the past decade, number of different industry examples where groups or coalitions have come together to try to create what I would put under the broader umbrella of quality labeling. So there was a 2013 effort from Haptique, which is now defunct, to my understanding. Another effort of industry collaborations through HIMSS called Exertia. That, as far as I could find, the last guidelines on a number of different dimensions came out in 2019. And then, you kind of look over to specific types of technologies like blood pressure monitors. And there's a current validatebp.org website that the AMA, American Medical Association, helps to lead the process for. And that's validated device listing criteria. And you could certainly see, that playing out across many different use cases as well. From a policy context, this really, I would say, hit more of a mainstream awareness and understanding through a law that was passed in 2012 FDA, my office, and FCC were all charged with producing a report on the understanding of mobile medical devices and other types of health IT devices. And I use devices more colloquially here, not necessarily regulated in all cases, and how the industry and risks could be considered for those types of scenarios. So, from the 2020 almost into 2023 now, since we're close to the end of the year, what we see coming forward into the future is, again, increased use of apps in clinical settings and for patients. We also see continued efforts by industry groups and coalitions, as well as, I'm sure, either at a state or federal level, policy interest in making sure that consumers are protected, that devices are performing, as they're designed. And so the bottom line is, we've got a significant opportunity, and I'm really glad that JIC has, convened this type of conversation to have broad international cooperation and coordination, and work with our colleagues in the standards development community to help advance the consistency of the work, common expectations across those many different dimensions, be it safety, privacy and security, transparency, other types of interoperability and standards conformance, as well as making efforts to make this information transparent and accessible to the broader community that doesn't attend a session like this. You all are the folks that kind of know the lingo, and I'm sure mostly digitally literate. And so it's really thinking about the populations that we're serving, that we're supporting, and making sure that they have easy and more intuitive access to understanding how all these technologies will affect their lives and will work for them in the future. With that said, you can find out more information about my office. That's on the next slide. And that really concludes my introductory, I'll call them the warm-up remarks for the rest of my panelists. And thank you again for having me.
Thanks very much, Steve, for giving us an insight on the activities in the United States in this area, and also underlying the need for having a standard like 82304. And we will learn now from Robert how this actually was pulled off.
Yes, thank you. And it's very exciting to see how much is happening across the world. And I'd like to tell you a little bit about the history, and then after my talk, Charlie McKay will provide you with the details of what's actually in 82304. So next slide, please. What we see is of course an enormous interest in mobile health. One of the things that started things in Europe, for those of you who don't know CEN is the European counterpart of ISO. So we're focusing on Europe. So the European Commission put out a green paper on mHealth already in 2014, which kind of set the scene for the policy discussion on what's needed to stimulate but also regulate this market, and how to make sure that people actually know that they're not giving away their data, that they can trust the services that they're getting through mobile health. And there were different initiatives also across European countries. So one of the main inspirations to pull off the project was the publicly accessible specification from the British Standards Institute, BSI. And that was a guidance for kind of the websites that wanted to compare different health and wellness apps, so that they could actually provide proper information to the public. Similarly, there was a technical report from Italy as well, and there's been work in other countries as well, and I'll go into some of the recent work later on in this talk. Already in 2017, this was also mentioned as a topic for standardization in the rolling plan for ICT standardization. So that was also an incentive for CEN and the European Commission to take this on. But the main push actually came from the vision that and the strategy that the European Commission published in 2018. And it's summarized in the next slide, where we really look at the digital transformation of health and care. And there is a real focus on patient and citizen engagement, also using digital services to really empower the citizen and transform to patient-centered care rather than the fragmented provider-centered care. So as part of that vision, there was also a need for common principles, also for certification to make sure that that it was easy yet safe to provide these services for companies, that they were protected, but also that the consumers were protected in that space. So that's where the push came from to actually take what was already going on and what was already there, to take that up in a standardization effort. So that's where we started on the next slide. We, we got funding from the European Commission to actually do a project on the quality and reliability of health and wellness apps. And given also the experience we had and our strategy as SEN to always work together globally, we quickly engaged ISO TC215, and there in the joint working group with IEC, we got good support and interest in doing this together. So the whole project was carried out by a SEN-led team, but with the full collaboration of both ISO, IEC, and also SENELEC, which is the European counterpart of IEC. Also, and I like to mention that specifically, is that we already engaged also HL7 International, and you will hear a little bit later about the Consumer Mobile Health Application Functional Framework, the CMAF, which kind of ties it into other criteria that HL7 has developed as part of their guidance for mobile health developers. So we're really seeking that that collaboration. So we actually did that. We carried out this project with the help of a lot of people, both in a Delphi study, but also in just comparing frameworks. Over 25 existing frameworks were studied. And I'm happy to mention also that the American Medical Association, which Steve just mentioned, has been engaged heavily in this work as well, so that we are aligned on what we're trying to accomplish. And we did look at what our outcome was compared to 20 frameworks that were reported in a WHO study. And it actually, we cover all the bases, and we added the ethics perspective. Rather than just 3 stakeholders, we actually had 8 stakeholder communities engaged, both in the development and in the Delphi study. And we are really looking at the full life cycle of an app. So we did a lot of work there, and we did reach out to a lot of people. So it's a truly comprehensive framework. Yet we did test it also, but Charlie will go into that it's usable. So it's not just a stack of papers that this is everything you need to look at. No, it's actually something that is usable, hopefully both from a manufacturer and from a patient perspective. So that was developed over the years, and it was also taken up already during its development. So we all know that we were hit by COVID, and especially in Europe, there was a push from the European countries to actually make sure that we have apps for testing, for tracing, for actually having access to public events. So what the European eHealth Network did, which is a voluntary collaboration of the European countries on the topic of eHealth, they published a COVID-19 toolbox, and they included the draft framework that we had just developed for people to use already, even though it was not a proper standard yet. And it has been used by a number of countries to actually make sure that the apps that they put on the market were properly assessed on the different aspects that our framework references. And another way that this was being used was also in Italy, where they also already used it as part of a tender to make sure that the people that were offering their services and their solutions to the ministry were properly assessed as well. So we already got use of our framework while we were developing it, and that was very helpful also in the development. So we actually published it July 2021 through the processes of all, well, the balloting processes of all engaged standards organizations. So we did get a lot of feedback, and we were able to actually address all that feedback in the final publication. And it does provide you with the actual requirements and how to visualize the outcomes. But again, Charlie will go into that as well. And one of the questions that might come to mind is, why is this called 82304-2? Because we said, well, it's part of a family of standards, and it started already quite a long time ago with 82304-1, which is the kind of consumer version of the medical device software guideline. So there's software as a medical device, where we have a software lifecycle model that has been developed, and 82304-1 actually does that for health and wellness apps rather than for medical device software. So some of the requirements are a bit lessened there. However, it is part of the same family, and of course, if you want to qualify for a robust build in 82304-2, then of course you can reference 82304-1 to say, well, this is our software development process, how we do that. So that's why we see this as already within CEN and ISO as part of a family of standards. Next slide, please. So how is this moving forward? If we go to the next slide, this will be used as guidance towards the single market that the European Union is striving for, so that the manufacturers, the decision makers, and the consumers actually are on the same level in terms of what to expect or what to put forward. And I think the next slide already tells a little bit about the EHDS. It has been mentioned already in different countries. We mentioned Italy already, but also the Netherlands is using this, Norway, Catalonia, which is a region in Spain. They're using our specifications to go forward. And there's other countries that already had set out to do these things, like the DIGA initiative in Germany, and another initiative also in Belgium. And they're looking to see if their frameworks can move towards the 82304-2, and the other way around, of course, if there's a necessity. The European Commission has also supported 2 EU projects, Label to Enable, which you will hear from Charlie about, and there's another project, Expand EH, which actually has more of the health and wellness apps in them. The EHDS, the European Health Data Space, which aims to create a really unified data space for health data, both for direct clinical use, but also for secondary use. They mention health and wellness apps as well, because they see that health and wellness apps need to interact and add to the health record data that's out there. And they are looking at the technical specification as a first part. Next slide, please. As I mentioned, that's the EHDS. So there's a data quality label for the health and wellness apps. Actually, the self-declared part is under discussion, whether it's a mandatory objective data quality label or a self-declared one. And the voluntary part is also being discussed. Wellness applications should have a label. So it's getting there, and we will be working on it, which is also on the next slide for the ExpendiH project. Next slide, please. And the ExpendiH project is expected to start 1st of January. We're still collecting the last signatures under the grant agreement. And basically what we're trying to do there is, and that's also the work where Sen is most involved in this project, is to actually also look at the technical requirements for quality labeling for consumer health products. So that will extend the 82304-1 into also interoperability requirements with the electronic health record exchange format, which is the core of making data available in a unified way across Europe. So with that, there's a lot to go and to do, and we look forward to taking this forward. But first, let's hear Charlie and see what he can tell you about the 82304.
Thanks, Robert. And before handing over to Charlie, a quick reminder to the audience: if you have any questions to the presenters, please post them in the Q&A. Now over to you, Charlie.
That's great. So just to introduce a bit more detail of what TS 82304 Part 2 covers, but also to talk about the Label to Enable project, which is has just started in the middle of this year to adopt and implement the technical specification, providing a certification scheme for use across Europe, but also looking at the broader promotion and adoption. So next slide, please. So at the heart of the specification is the definition of a label, but for health apps. So based on the EU Energy Label, inspired by the EU Energy Label, defining 4 different areas of quality and giving a score for each area based on a set of questions, criteria, and then rounding that score up to form an overall quality score for the health apps. And there were kind of 2 things that were novel about the way the standard was developed. One was starting with the label as kind of a core motivator, and the other was looking at the naming of things to ensure that they're accessible. So there's quite a bit of work done with groups with low health literacy to identify the naming. So healthy and safe, easy to use, secure data, and robust build are not terms that those of us who play with health information standards regularly use, but they were identified and established quite carefully as phrases that the user community do understand and recognize. And similarly with the labeling and the images on the label, a lot of work was done with designers, but also with stakeholder engagement to confirm that those images really do get interpreted correctly. So if we just move on to the next slide, what the presentation of those scores, so if we just click again, the overall score is displayed like the overall score for a white good, where here you can see the labels. Click through, please. And so that's the overall score label. You click through on that, and you get to see the label with the marks, and then click through again. And so that gives you a link through to the full quality report. And we're doing something very similar with 82304 Part 2, where you get an overall score for the health app, but behind that, you've then got your 4 areas, and then behind that, you've got the answers to each of the 80-odd questions that are in the assessment framework that the user can click through and see that quality report. So there's real transparency there in a layered way so that people can see what the quality of a health app is. And that's targeted both at the end user, the user of the health app, but also at the professional community, because work has been done looking at where do we need to build trust. And in order to really drive health and wellness app adoption at scale, we need to have healthcare professionals and the caring professions aware of and comfortable and confident in recommending health apps. And that's really a key role for this labeling initiative. So if we go on to the next slide. So a lot of research has been done on how people do select apps. And at the moment, there are a lot of apps in the app stores that are for health purposes. And people really don't know what criteria to use to select them. So they tend to just pick the first ones in the list. So if we move on to the next slide. And very often they don't even pick the first one in the list. They don't pick one at all. So we saw that they are being used, but they're not being used nearly as much as one could expect. And the biggest block is the sheer number of health apps, and I don't know which one will help me. And if we move on to the next slide, we see that for health professionals, the two blockers that really stop them recommending health apps are a lack of knowledge of which ones are effective and a lack of knowledge of a trustworthy source to get hold of the apps. But that lack of knowledge of what's an effective health app in the way that healthcare professionals know whether a treatment or a drug is effective is a real blocker. And that's the thing that we're really trying to address, both through the development of the technical specification, but also through the certification scheme and the promotion activity sitting around it. So if we move on to the next slide. There have been a lot of projects across Europe and across the world, but looking at how to do health app assessment. The mHealth Hub got a list of 20 odd of them across Europe, and we analysed those as part of the development of the standard, and we're also coordinating with them as part of the Label to Enable project, because in order to get that trust and consistency, we do need the various health app assessment frameworks to converge. And that was kind of the vision behind the ISO standard in the first place. And if we just click through, we can see that a number of these frameworks, the German DIGA is one of the most successful. They've only approved 30 odd apps that have now been prescribed 45,000 times in the last year. So that sounds quite a lot, but that's on a population of 73 million people. So in terms of scale and adoption, we've still got a long way to go. And if we click through again, we've also got the Belgium mHealth pyramid, which has got a single app approved so far. So a real opportunity to scale up, and we're going to do that if we manage to collaborate internationally, because this really is an international market. It's not a national only market. Clicking on to the next slide. A really interesting paper in Nature, I think this was in, talking about the different health app assessment frameworks across a number of countries, and really recommending that what's needed is collaboration internationally, which is what obviously the ISO and the standards development process is intended to engender. And certainly from a UK perspective, we've learned that we've been through a number of different health app library initiatives. And it's exciting to see this level of international collaboration and interest. So if we move on to the next slide. So what has what's been done within the technical specification to try and help bring those things together? Firstly, we've been comprehensive and we've looked at health and wellness apps as whether or not they're medical devices. So bringing the criteria that apply for medical devices and not replicating or creating additional criteria, but really providing a seamless ramp between the two was an important part of the development process. Really working to be evidence informed, so we've got the criteria, but also being inclusive, as I mentioned earlier, testing with low health literacy, and being proportionate, so trying to narrow down on what are the key questions, the key criteria that are needed to assess the quality of an app. And going through a lot of feedback, as Robert mentioned, we did a Delphi study with 83 experts, but we also, throughout the development of the standard, had regular committee drafts that were circulated, and we got substantial feedback on, as well as the balloting process itself. So the process of developing the app has established has learned from those previous efforts, but also bringing in the label has made it as a communication means really has been a significant additional step. So if we move on to the next slide. Again, Robert mentioned the different communities that we've been engaged with through both the development of the standard, but now looking at this certification scheme and adoption program, looking at how the label helps app manufacturers to demonstrate the quality of their product, but to be able to do that across multiple countries and consistently. So do that in a way that is cost effective. Having to go to multiple different assessment agencies to prove the safety and then to prove the cost effectiveness of your app. If you've got to do that in every different country or with every different provider organization, that's a massive amount of administration, both for the app developer, but also for the health and care authorities and the provider organizations that need to do those assessments. So looking to reduce the effort for the app manufacturers, reduce the effort for the health assessment organizations and the healthcare and care system organizations, but also provide that consistent quality assessment for the healthcare providers and the professional societies. So by having a clear, transparent, standards-based process for establishing the criteria, we can build trust between the healthcare professionals and their societies and the system of health app assessment, so that they're comfortable recommending apps and using those quality assessments to inform their decisions. And clearly the app stores and the libraries are another stakeholder group that we really want to help by giving them a consistent label that they can use. And so, moving forwards, that would be an ideal if we could start seeing the app stores adopting and promoting the label as well. So moving on to the next slide. The project has got 14 or 15 collaborators in it. That's you can see their logos there. Started in June 2020, runs through to May year after next. Moving on to the next slide. And it's really there's two sides to the project. There's the certification scheme and the health app assessment process itself, which is exercising the technical specification and assessing apps against it, and then testing that process by having the same app assessed by multiple organizations. And then there's a significant other tranche, which is looking at how that label is going to be used, how those different stakeholder groups engage with the label and find it useful or not, and then working on improving that so that we really do deliver value across the ecosystem. And if we move on to the next slide, and that kind of reflects the two different areas of interest from the European Commission, who commissioned this work to build the digital ecosystem, to build on that the digital platform, the European digital platform, but also to promote adoption. So we've got those two different strands, if you like, that are working together in the project. And then if we move to the next slide. And the three pillars there: building trust, ensuring usability, and then promoting adoption. So the three strands: ensuring you've got a trustworthy process. And a really crucial bit of that actually has been developing the certification scheme using the ISO Casco standards for conformity assessment. And that's something that ISO's TC215 has been sort of wanting to build in over the last few years. And this is really an opportunity to demonstrate how that can be done for these health informatics standards. And the Casco 17,000 standards for conformity assessment are really good framework for doing this sort of thing. So that's quite an exciting piece to bring that into the health software assessment space. And then the work promoting trust and adoption, use and adoption by engaging with the different stakeholder groups. So moving on to the next slide. Robert mentioned some of these early adopter projects. There are a number, these two labels came from the Norwegian project, I believe. And the Label to Enable project is certainly working with anyone within Europe and beyond who are interested in doing 82304 Part 2 based certifications, because we really do want to establish a global framework for doing conformity assessment against the specification. And moving on. Again, we can click through this quickly because Robert mentioned that the European Health Data Space is mentioning labeling as being part of the requirements going forward, so pointing to how this fits in with the regulatory requirements. And that's one of the other things we're doing within the Label to Enable project, and I think this is quite important, is fitting health app assessment into a broader context of what other assessments and testing do you have to do for compliance with regulations. So looking at the GDPR and other European regulations that need to be complied with to ensure that we're minimizing the burden for the developers and the assessment organizations. So all of that conformance assessment can be done as smoothly as possible. So moving on. And that's, well, moving on and moving out, actually, that's the end of the presentation. The other piece perhaps worth mentioning is that we're looking, the expectation when we finish the development of the technical specification is that we do a revision project, and there's definitely a need for that to keep the criteria fresh, but also to ensure alignment with the other ISO standards that are under development. So there's a number of those, and there's certainly some work to be done there to keep the standard moving forward, as well as the adoption activities here.
Thanks a lot, Charlie. So with setting the stage by learning what is going on in the US and getting an understanding what is 82304 Part 2 about, it's now time for our panel. And the panelists from the contributing SDOs, let's say, to learn what they are doing in this area. And the panel will be moderated by Frank, by Pierangelo, I believe.
No, I will do it this time.
You will do it. Robert will do moderate it. Okay.
Pierangelo and I kind of alternate our roles.
Yep.
So thank you, Andreas. And As mentioned, we like to hear from our other SDOs. So far, especially my talk and Charlie's talk has been highly focused on the 82304-2, which is in the CEN ISO space. So first of all, I'd like to ask Frank Ploeg from HL7 in the Netherlands to talk about the way HL7 International looks at this development and how it links into their own activities in providing standards for mHealth apps. Frank, take it away.
Okay, thank you, Robert. Yes, I will inform you on the HL7 Consumer Mobile Health Application Functional Framework, and it's the last time I've pronounced it completely, so I'll refer to it as CMAF. Next slide, please. First of all, let me introduce myself. I'm an enterprise architect at the University Medical Center in Groningen. I was part of the TS 82304-2 project team, been a member of HL7 for a long time, and I'm a co-chair of the Mobile Health Working Group, which developed the CMAF standard, and I've been involved in working on the CMAF standard for the past 4 or 5 years. Next, please. So the CMAF standard was originated as to provide a framework for the assessment of the most common foundations of mobile health applications. It's listed down here. I'm not going to read it all out. And it was originally based on also to create an assessment environment where attestation, endorsement, testing, etc. could be accomplished. Next, please. Why CMAF? Why the need? Well, CMAF is part of the originated as part of the comprehensive HL7 framework, and because it was evident already a couple of years ago that we needed something to assess and give a basis of how mobile health apps should look like and should consider. Next, please. As far as the relation goes with ISO TS 82304-2 and CMAF, as I said, CMAF is part of the extensive framework of HL7. It's basically built on the HL7 EHR system functional model and the HL7 PHR system functional model, and it's interchangeable with those. It creates the possibility, the way it's structured, to make profiles or focus on specific realms and types of app. But it's also it has also been a inspiration for TS 82304-2 and vice versa, and I've been trying to make a lot of alignments between the both standards so that we should approach it in the same way. The difference in approaching is in the fact that we work with requirements that either shall be implemented or should be implemented or may be implemented, and some of them have also if statements whether it's applicable or not. Next, please. The domain CMAF covers is the life cycle of the app from birth to grave, and all those areas are they have their own requirements with shall, shoulds, and mays. Next. We're almost normative. We have had a second STU2 ballot, which was completed last year, and we're working towards the new ballot to make it normative, and we're working to migrate it to fully EHR FSM and publish it in the tools of HL7 so it can be worked. It can be used in accordance and in combination with all the other tooling within HL7 environment. Next, please. The typical uses, simple use from A, which is just your health app on your smartphone, to C, where the smart app is, where the app is interacting with EHRs and PHRs, which is B, and so it covers quite a whole spectrum. Next, please. This is the way the requirements and the conformance statements are set up, with the conformance strength this is an example of the general product info. All the chapters you've seen before are built up like this. They have a description of the requirement and a strength, and accordingly the apps will be assessed to these levels. Next, please. And from that, we have been trying to build a label that's informing the consumers about the possibilities of the apps, quite accordingly to the TS label. Next, please. The scoring mechanism we try to develop is to make a transparent scoring and to make it easy to understand for everyone. So especially for self-assessment, but also for the consumer and health provider needs. Next, please. We are weighting every aspect by domain. Just showed you the domains, and then it's based on the score of the conformance strength. Next, please. We came up with a system like this, and we calculated up, and then we have a total score. I will get back to this later. Next slide, please. The next 3 slides are mostly about the expressing the needs. They come from the general presentation on this subject to why we do need ratings. Well, I think all the previous speakers have explained that enough, so you can skip, and you can skip this one. It's nice to read, and you can skip this one. It's all about the same stuff. Based on what we're doing here, I think we should reformat our CMAF label and try and seek participation and collaboration so that we get one accepted system of scoring and labeling. And we will continue to work very closely, hopefully, with the 82304-2 community. And that's it, I think. Yeah.
Thank you, Frank.
Thank you.
It's exciting to see that that we're working from the same background, looking towards either an energy label or a nutrition label, but we're definitely on the same track, and hope to see things moving forward in the near future. Next, I'm very happy to introduce our GS1 representative, Phil Archer, and he'll say a little bit about what GS1 is for those of you who don't know them, and you actually saw a sneak preview already on the slides that Charlie presented. So, Phil,
thank you very much indeed, Robert. Thank you. So yes, hello everybody. Thank you very much indeed for your time today, and thanks to JIC for the invitation. If you don't know GS1, we're usually known as the barcode people. We cover a whole load of industries, most notably retail, with the people that go beep at the checkout. But we have a very significant interest in the healthcare sector, not least with two-dimensional barcodes like this, that you will see on billions of pharmaceuticals and medical devices. You also see our barcodes on assets around hospitals. That is the beds, the surgical equipment, all the things that make any kind of complex building work. And the reason that people come to us for help with this is that we specialize in globally unique identifiers, all supported by an ISO standard. It's certainly in the pharmaceutical world, you will very often see these 4 pieces of data encoded onto something. So when you're building a healthcare app, you might want to include the ability to scan a medicine, to scan a medical device, to whatever, and connect the patient to some digital information about the physical thing in front of them. Maybe some instructions how to use it. If you're talking about an asset within an operating theater, when was it last maintained? It's gone wrong. Who do I call? There are all sorts of questions that you as a clinician or as a healthcare worker in some other form or a patient, all sorts of questions you might have about this physical thing in front of you. And what the work I've been leading at GS1 is about making that possible, making it possible to ask a question of the thing in front of you. And that's a capability that can be included in the kind of apps that we're talking about in this session today. So these four things, we have what's called the global trade item number, the GTIN. That's actually the number that when it's in a one-dimensional stripy barcode goes beep with the checkout. You see them all over the place. But in the medical world, we're also going to have a batch number and an expiry date, a serial number, and very often another national number that needs to be included as well. But usually it's those four, possibly with a fifth. And how do they get encoded? If you are producing an app or assessing an app as to whether it's actually going to be able to read these barcodes, you need to have some understanding of how it does that. In fact, those four pieces of information are encoded, click, in a string of characters like this. Except I'm lying, because that's actually the way we make it look human readable. The actual structure, click, is like this, except there's no color coding to help you. It's just a string of characters. And if you don't know what you're talking about, it's really hard to understand. Now, the barcode printing and scanning industries do understand it. This is an extremely efficient way of encoding those bits of data in the smallest possible two-dimensional code we can. It's very efficient. It's designed for that efficiency. And the healthcare community around GS1 strongly endorses this as the one way to barcode a project. And they don't want any other. They don't want a QR code on there. They don't want anything else. The reason for that being that clinically, if there's only one barcode to scan, you're not going to scan the wrong one. There's no possibility that two codes might have slightly different information. If you've just got the one, it's clinically safer than having multiple codes. But as I say, that string of characters doesn't make a lot of sense to a lot of people. Click. How about this instead? It's the same information. I can take that weird looking string of characters from a GS1 data matrix and I can turn it into something that looks a lot more familiar. Still got the same identifiers, still got the GTIN, it's still got the batch number, the serial, the expiry date. Now the syntax is a little bit different, but it is very, very precisely defined. You can't mix these things up and move them around and put them wherever you like. There's a very, very specific syntax. But something to emphasize is that if an app does that transformation from something written in a GS1 data matrix, that string of characters that is meaningless to most people, into a web address, it actually doesn't matter what domain name you use. You can point to your own data service or another data service that you trust. So you have that choice, but you're using the standard. Why would you bother to use a standard when if you're going to link to your own database, you decide what syntax you use? Click. I'll tell you why. Because if you have a common syntax that understands those identifiers, that understands the difference between a global trade item number and a batch number and a serial number, and understands that 6 digits that actually translates into an expiry date, if you have something that understands that, you can start to do some clever stuff. If you translate it into a URL, go after this thing we call a resolver, that is, it resolves those identifiers, you can start to be clever about it. And your app can ask those specific questions of the thing in front of you. Who made this? What's the dosage? What are the symptoms? Can I replace that patient information leaflet that in Europe alone, I believe the number of those leaflets that gets put inside medicine packs is 6 billion per year, just in Europe. Which means that if you had a printer spitting out 2 per second, it would take you nearly a century to print 1 year's worth of European leaflets. So we can do better than that. We can link to the electronic version of that. And by default, you're probably going to go straight to the information for patients. But if you say to the system, actually, I'm a clinician, I want the clinical information, then that resolver can redirect you to that clinical information, or to a video that helps children understand it, or to regulatory information, or to pharmacological information. You could actually make that product part of the pharmacological data sphere, if you like. You can link to that pharmacology, which can link to the chemistry and all the rest of it, and maybe get some feedback from your patients to give you more, if you like, free research. So what we're talking about here is a way which I don't have time to go into details about, but essentially we can go from a standard GS1 set of identifiers through a system that you operate to get to different sorts of information that could be useful to different end users. And we can do more than that as well, because what we at GS1 are not in the business of running data systems of this type, especially regulated healthcare ones. But people like Johnson & Johnson have set up their own GS1 conformant resolver. And other people are very seriously considering doing the same thing. Or there are national repositories of patient information leaflets, things that your apps might want to access. And so what we offer, anyone can do it as well. This is open standard, do what you like. But one thing we do offer is the ability to go through our system, which will then redirect you, if the manufacturers have asked us to do this, to redirect you to the correct source of information. So one of your quality criteria might be, does this app understand GS1 barcodes, which are essentially ubiquitous around the world? And does it understand how to go from that barcode to manufacturer authorized and regulatory authorized information? Those are the kind of things we can do. Now, to make it easy for you, we have another set of resources. We're in the process of finalizing this. It's not quite ready yet, but it's coming out in the next month or two, probably January, maybe as late as February. But we want to make it easy for you to use this. We want to make it easy for you to add to existing apps, or indeed create new ones that can understand what a GS1 barcode contains and how you can use it. So we're in the middle of making some software libraries to work with Android and iOS apps. So that's the GS1 digital link system. I've gone through it fairly quickly because I have a short space of time. There's a load more I could tell you, and if you want to know, then let me know. Thank you, Christian. Last slide, just my contact details. And thank you, Robert.
Well, thank you very much. Looks like very exciting work and very many possibilities that some of the app developers might never have heard of. So hope we can set up that consortium or that ecosystem of people actually using these wonderful resources. Thank you for that. And with that, we move on to Dave Kwan from IHE. And before giving the floor to Dave, I'd like to make sure that everyone's aware of the Q&A. We want to do some question and answers after this panel. So if you have any questions, please put them in the Q&A. And that's not just for the panelists, also for the previous speakers. Dave, thanks for joining us from IHE Canada.
Thank you, Mr. Chair. Thank you for allowing me to fill in for Derek Ritz. My name is David Kwan. I'm a member of IHE Canada, as well as a member of IHE, the IHE radiology domain. Derek's given me a very ambitious slide deck, so given some time, I may go off script and we'll go from there. But what we're going to talk about today is not so much on the mobile app, but the healthcare provider apps, namely the emerging artificial intelligence solutions that we're seeing for the provider itself. In this regard, it's really the regulation we're talking about of software as a medical device, or what we're going to call it SAMD. Thanks for advice to this slide. Again, very ambitious here. We're going to cover these 5 points in 5 minutes. Next slide, please. So first off, what does the role of IHE play in the digital health SDO ecosystem? Next slide, please. At the top level on the left is base standards developed by SDOs, and some of them you're very familiar with. Some of them are organizations in JIC. They develop the base standards, ISO, HL7, DICOM. These collection of base standards are referenced by implementable, testable, interoperable specifications. In IHE, we call them IHE profiles or technical supplements. As an instrument of governance, the vendor solutions demonstrate adherence to these specs in or at conformance testing events. IHE Connect-a-thons are such events. We're starting to venture into project-a-thons. Care delivery network operators, such as ministries of health or healthcare provider organizations, leverage conformance solutions to support digitally enabled healthcare for their populations. IHE's value proposition really it lies in the middle two areas of this flow. Next slide, please. There's two streams, IHE domain committees. As I said, I'm a member of the radiology domain. I'm responsible for thing one, that is developing implementable, conformance testable engineering artifacts or profiles. Second stream is deployment committees like IHE Canada, IHE Europe, do thing two. They host conformance testing events. Over the last few years, IHE Europe has conducted very dynamic connectathons and help enable the adoption of interoperable specs across national care deliveries. Next slide, please. So what is SAMD? Apologies, this is a very busy slide. Derek has assured me that there's a lot of information hidden in here. He's going to publish or pass along to you a slide deck that has the URL links. Really, the takeaway from this is, according to Health Canada's guidance, software that meets the definition as a medical device is regulated as such as if a software is processing medical images or making recommendations related to the course of care, it is SAMD. Next slide, please. The Canadian SAMD regulations are consistent with those of other countries that are part of the International Medical Device Regulators Forum. Next slide, please. So how do we regulate SAMD today? We regulate it based on specifications that are existing. I think what we're going to get to by the time you get through these next few slides is, again, using Canada as an example, regulation of SAMD has pre-market focus and is based on a risk-based approach. This is not good enough, as we will see. SAMD manufacturers must have a quality management system, QMD, adhere to ISO 13485, which is an ISO 9000 based standard specific to medical devices. This workflow, and I know it's busy, is an example that illustrates top-level processes followed by a Canadian digital healthcare software firm that successfully completed its ISO 13485 certification last year. Next slide, please. How do we plan to regulate AI SAMD and other new digital health innovations? I could get into a whole different subject matter, and a lot of people call it AI, but it's AI in the end. It looks like magic, but how do we still, even though it's not AI, how do we regulate that? Next slide, please. And this is a very important point, that emergent properties come with emergent risks. Presently, the experience from the field is showing that AI solutions and AI algorithms are really a different beast. Going off script a little bit, from radiology experience to date, last year, as of last year, there were about 150 radiology AI applications or algorithms that were approved by the FDA. That's just tip of the iceberg. A radiologist is faced with tens of thousands of different diseases and different applications. So that's what's coming. There's going to be tens of thousands of AI solutions that are coming down the pipeline. And with this, taking this type of approach, which is on this slide, will help. We need to learn from, it's an ongoing iterative process of monitoring that we're going to talk about in the next couple slides. Again, busy slide. The takeaway here is AI for Health is a joint focus group of International Telecommunications Union and WHO that was formed. The joint ITU WHO focus group was created to specifically look at AI for health. One of the outputs from this group is on AI benchmarking workflow. This pipeline leverages training and test data to do validity testing on machine learning-based algorithms. Such an evaluation approach will inform pre-market certification and, most importantly, post-market monitoring of AI SAMD. What role does IHE foresee in playing related to future SAMD innovations? Thank you. Next slide, please. IHE's new five-pillar strategic plan was published this past September. Pillar 3 of the AI new strategic plan is focused on bringing evidence-based care to scale. As we have seen, digital solutions that operationalize an evidence-based care will most assuredly be subject to SAMD regulations. Pillar number 3, IHE domain committees will continue developing profiles or technical supplements that will focus on evidence-based care, such as computable care guidelines. Our domain in radiology has started working on AI results. What we're currently doing is actually starting to build AI right into our technical supplements, our workflow. And one of the things we identified was what happens when a radiologist disagrees with the AI results. So we're starting to work on what are the messages that actually start to go back upstream. And part of that is it will flow into the monitoring, the post-market monitoring. IHE will engage with clinical groups such as CDC, WHO, Diabetes Canada. Today publish care guidelines, mostly in digital paper format. Again, these will be converted into computable formats that will flow into not only AI applications, but other clinical applications. IHE will collaborate with any EBC centers of excellence and co-host events, focusing on authoring governance adoption. So one of the core strengths of IHE is actually, we're not really a standards development organization. We actually leverage standards like ISO, HL7, and hugely on DICOM. But more and more, we are starting to work with HL7 Fire. And our strength is developing tools that we can conformance test these EBC solutions. And right now, the EBC testing is being considered as a regular track in IHE Connectathons and Projectathons. Next slide, please. With that, this is our summary slide. I'm not going to read this to you for trying to meet my time period here. So with that, I'll leave it to any questions in the question period. And hopefully if I've met my 5 points in 5 or 7 minutes. Thank you very much.
Thank you very much. And yes, there will be Q&A at the end of the presentation. So great to get an insight into what's being developed, co-developed with the government as well in this field. So looking forward to sharing that across the world as well. I'm very happy to announce our next speaker, who's representing HL7 in Japan. And Naoki Nakachima will tell you more about what's going on in real life with real patients. So take it away.
Thank you, Robert. This is Naoki from Japan at 2 a.m. December 1st right now. And today I want to talk about the importance of technological standard and also clinical standard for application quality. Let me start. Next slide. Next, please. Several years ago, we decided 2 item sets, core item set and self-management item set for chronic disease. NCD, non-communicable disease, as diabetes mellitus, hypertension, dyslipidemia, CKD, with collaboration with 6 Japanese academic clinical society, led by Japan Association for Medical Informatics, with the support of the Cabinet Secretariat of Japan. After that, we also established the recommended configuration for personal health record. Next, please. This is item sets for NCD. Colored part, blue, orange colored part, the core item sets, and marked parts, marked items, self-management item sets. We have total 41 items, and we decided item name and granularity, and also the way of the expression. Next, please. On this, the item sets, the left half is the item sets, we decided recommended configuration for PHR. This is the sheet for the non-affected subject, I mean the healthier subject. Next, please. And also we decided the sheet, optional sheet for the diabetic sheet, and also for the hypertension, dyslipidemia, CKD, and also the ischemic heart disease. We decided risk stratification threshold and alert threshold, and also the period for sending reminders, and the reminder period. Next, please. This is magnified, the slide. The left half is the minimum item set, and the middle, the 12 months, is a period of the reminders. And green, yellow, orange, red is a risk stratification, and we decided the threshold, but that for the healthier subject and also the affected subject. The lower half, the threshold for the alert. Next, please. That was only uncovered 4 years ago, and from this year, Japanese government started to provide fund to support for digital health clinical guideline development for 3 years. And the diabetes, hypertension, chronic CKD, and dementia, and sarcopenia-free, and mental health, women health, to establish effective, safe, and economical digital health world. This is a story of the clinical standardization in Japan. Next, please. Of course, the technological standardization is really important. So Japanese government also promoted HL7 FIRE implementation for 3 years. Look at the bottom one. Based on this HL7 FIRE basic specification by HL7 International, this is a newest version in 2019. Our national FIRE team established JP Core version 1 just 1 year ago. This is domestic standard. And also they established the 4 use case standard using FIRE, prescription and health checkup, and patient administration summary, and patient introduction letter. So we established this by the March this year. And now we are implementing this standard to the EMR and the PHR also. Next, please. This is one example. We are conducting PHR POC using this kind of the application in the smartphone, using minimum item sets as the clinical standard and smartphone FIRE as the technological standard. Next, please. So we believe combination of technological standardization and clinical standardization creates high quality data Thank you for your attention.
Well, thank you very much, Naoki. It's very good to see how you actually integrate different parts of the standards into something that's really useful for both clinicians and patients as well. And I can see that we will and can take this further also on a more wider scale, especially when there's strong interest also from the clinical community on a global scale. And of course, diabetes is one of the key topics that is being discussed across the globe. So thank you very much for your contribution. And now I'd like to ask all panelists and presenters to open their videos once again. We did get some questions in the Q&A, so I'll start by asking Charlie if he's still here. I don't see him. Yeah, thanks, Charlie.
Yeah. Hello.
We did get a question in the Q&A from Elpoveri on what to do when your country doesn't have an app-assessor. So can you elaborate a little bit on that?
Yeah, so in terms of the Label to Enable project, the app assessment, the conformity assessment criteria are managed within the scheme, and then any number of assessment organizations can license and engage with using that scheme to assess apps, either within a geographical region, within a country, or across different countries. And the criteria themselves are not country specific. So what we'd anticipate is that there will be some existing assessment frameworks that will want to include 82304 Part 2 assessments as part of their sort of portfolio of assessments they do within a country, and some will want to offer those services across multiple countries. So the expectation is that there will be assessment organizations that will offer that service, even if you don't have a national policy-driven assessment framework.
Well, thank you. And of course, there's this question of language, but also of some local requirements that might be taking into account. And maybe that's a good leeway to Steve Posnack, representing ONC. And then would you feel that the framework needs localization for the US, or can you make do with the generic framework? How do you see that?
Yeah, absolutely. So, I mean, I think in general for international consistency, there's always an interest in striving to remain consistent. I think everybody recognizes within each of the local or domestic markets, there are either particular areas or specific review criteria that may be unique or culturally relevant or specific to particular market needs. But I think in general, in the direction of quality labeling, and as we go in this look at this overall context, the more that we're able to remain aligned, the better. And I think that's also from a market competition perspective too. Many of the software developers that operate now are global, and they want access to numerous markets. I think we equally have a similar interest in not driving them crazy, to speak colloquially, and keeping things as close to similar as possible, and making clear where there are differences, what the rationale for the difference is. Sometimes it may be a legal requirement or something along those lines, but that would be some key factors that we would keep in mind. And certainly as we get down into the details of specific terminologies or other types of standards, that's again where I know we've seen each other deviate a bit from the domestic and international spaces, but limiting all those makes the friction as little as possible.
Thank you. Anyone wants to follow up on those comments? And it is something that we see on a global scale, of course, and there's this balance to be found. So Dave, you have your hand raised.
Yeah, just to supplement what Steve was talking about. There's been a couple of initiatives that have arisen, and I think we need to pay more attention to it. And that is translating from our use of medical jargon and acronyms that we use in clinical care, and translating that to more patient-friendly language. You know, I see a lot of you guys are really working really well on the mobile apps, but for us to flow image from healthcare providers to the patient, I think what we're learning is we can't use the same language, in other words, and then there's that translation problem. And I know earlier on I was involved with a working group that was out of the Middle East, and there's different dialects in Turkey alone. There's something like 14, 15 different dialects, and it's very it's hard. They have a very advanced digital health system, but you know, again, most of the care providers are trained in English, but the patients aren't fluent in English. So when it comes to that translation, one of the areas that I've been keeping an eye on is use of standard ontology, namely SNOMED CT. More and more languages are being adopted. There's new national dictionaries, but there's a lot of work to do. So it'd be interesting to hear what this group is when it comes to the use of patient-friendly language in apps and everything else. Now, from a quality aspect, it's hard for us to tackle that.
Yeah, thank you. And I was hoping Charlie would step in, otherwise I put him on the spot. You did already show different language quality labels, so I was hoping to expand a little bit on the vision of your group.
Yeah, so I was going to catch the ball and then kind of drop it almost immediately. What we did do quite early on in the development of 82304 Part 2 was have a long discussion around interoperability and these kind of issues about what does the data look like that you're collecting in a health app or presenting in a health app, surfacing in a health app, and we decoupled that from the other data quality issues, so other app quality issues. So within the standard, we've stated that you've got to be clear on that. You've got to be clear on the intended users, either by geography or language, and so on. So being clear on what your intended scope is a really important quality criteria. But the data requirements and the data standards that you're supporting, we've recognized should be decoupled, certainly at the moment, from the health app quality criteria, so that the health app quality label defined by 82304 Part 2 and tested by Label to Enable requires that the APIs and the data definitions and the sources of the data are well defined, but it doesn't say what they should be or mandate any particular APIs or terminologies that should be used. But it certainly is an area where standardization is needed, and the quicker we can move to a common approach to that, the better it's going to be for people developing products and people using products.
Thank you, Charlie. And of course, this also links with the way that Naoki Nakachima mentioned the data content part for his work, and so basically you're saying the label doesn't yet include that type of assessment, which I think is quite okay. But maybe we can reverse the question and ask whether Japan is looking into adding the quality label to the data conformance assessment that you're putting forward for your diabetes products.
Yeah, actually, we are just starting this kind of the quality labeling. I think this is just beginning. To establish the guideline is just beginning to making a label, quality label, I think. And I think usually we think only about the single application, but in the future we think we have to merge the application use. I mean, for example, telehealth and PHR, and maybe plus digital therapeutics like that. So we have to think about the application labeling. I mean, the quality of the matching of this kind of the multiple service or multiple applications. So, for example, we usually use the digital therapeutics. We just input by the hand, but maybe some the PHR data can be used for the digital therapeutics. So the matching is really important. So I think this kind of the quality evaluation is also very important in the future. Thank you.
Yeah, thank you. That's very insightful and very helpful. And what I also like to pass on this question is not as much in terms of data assessment, but if we're looking at the digital link where that Phil talked about, that's also about having access to information, and would that be a quality criteria in the label as well, or how do you see that, Phil?
Well, I think there are many labels that appear for different reasons. Obviously, the focus of this session has been around labeling the app itself and assessing the quality of the app itself. But one of the things that an app can do, of course, is to recognize labels that go with individual products and medical devices and other sources of data. And one of the things we're looking at that is directly related to quality and trusted information is the area of verifiable credentials, whereby we can, we and we hope other people will associate manufactured products with not just information that says this thing is certified according to this particular standard by this body, which got its authority from that body, but those kind of things can be cryptographically ensured and tested. And what that means is that part of the quality of a medical app, a healthcare app, would be that it itself assesses the quality of the information it gets. And so you could get you'll get data from one source at least, but maybe multiple sources. And if that sources of data includes external certifications, one single set of standards from W3C and a few others will allow you to cryptographically verify that those things are true. You don't have to call home every time. All the data you have is there. You just need the public signature, the public key. And so I think what these apps can do, and the quality labeling we're focused on today as part of this ecosystem, is to help users understand that a logo or a label isn't enough. Where did it come from? Who said it? Prove it. I can put a label on anything. Prove that it actually means something. And we can do that, and we can work together so that the apps themselves provide that information, that trust assurance for clinicians and patients alike.
Thanks. That would be another area to investigate as well. That's
well, I'd certainly jump in and confirm that when we are looking at what are the criteria that people care about, being able to really clearly identify what is health information and what's advertising, and the stuff that is editorial content that is claimed health information, is there evidence behind that, and how supported is that? That's very important as part of the quality of the product itself, and that's certainly included in the criteria that we're assessing. And I think as we look to revise the standard going forward, that area is one that we could look to link up so that we've got more automated confirmation and that sort of thing.
Good, thanks. One of the things that I'd like to follow up on is this notion of having an ecosystem of different apps, applications, systems that need to work together, especially around digital therapeutics that Naoki mentioned. I was reminded of a project, or actually it's not a project anymore. It's a part of the infrastructure in the Netherlands that Frank can probably tell us a little bit about. It's on koppeltaal, which is of course a Dutch word, but it's actually aimed at being able to order digital therapeutics in an e-health platform from your electronic patient record system, electronic health record system. Frank, can you tell us maybe a little bit about what's going on in koppeltaal?
Well, as you put it, like ordering an app from an EHR, if I understand you correctly. I think what I've done is mostly done that in the MedBij context, which is a program in the Netherlands, and which is also addressing the needs of a single language, single content, detailed clinical models, if they were called, and maybe patient-friendly terms. They're all addressed in that same context. And we're developing methods to actually order apps from the EHR according to the official standards, to connect them with the EHR, which is also part of the CMS standard and also part of the HL301, based on internationally, I should say, I should hope internationally, derived models and transport specifications. Does that?
Yeah, I think that helps, and I think it also is worth mentioning that there's already across the globe several initiatives to actually get the results from those interactions back into the EHR, specifically around questionnaires that are on an app, but the actual content is then digitally transferred to the EHR. So to kind of Dave, yes, you have your hand raised.
Yeah, just to supplement what you just described, and Frank, in Derek's presentation, he talks about CCGs, or computerized care guidelines. And so like you talked about diabetes. Diabetes does what we call a clinical guideline or pathway for the patient. And in that clinical guideline are the latest evidence-based recommendations are built into that guideline. Mainly today, it's digital paper. It's like a flow chart, and all the decision points, all the inputs. When you describe inputs, they are from a question or a questionnaire. And that's perfect for a digital app to be rolled out that way to a diabetic patient. They have an app and they answer the question, and the question is actually prodded by either an action described by the clinician or even a medication order. But the value that's given by computerizing it is huge, because you can roll out the latest evidence base, because a guideline published today takes anywhere from 10 to 17 years to be adopted in the field, which is crazy if you think about it. And these leads to errors of omission, where because there's just so much research going on that clinicians cannot keep up. So computerizing it makes a lot of sense. And that's what we're working towards on IHE, is now to start being able to test those electronic computerized guidelines. But most importantly, we need to have some harmonization of all the inputs. I think Steve mentioned it, terminology is a huge one. But the beauty of this is now marrying consumer or patient maps right alongside the provider apps. and they have to work in orchestration. And I'm seeing that term of orchestration come up time and time again in what we do. I just wanted to add that because there's a convergence of everything we talked about here today.
Yeah, thank you. And Charlie.
Yeah, I'm really interested in that piece. I'm doing some work with NICE and the Professional Record Standards Board in the UK on that issue of how do you get to computerized guidelines, and the first step being what are the data items that you need to feed that. And I was really interested in seeing that diabetes piece that you're doing in Japan, standardizing those data items. What are the data items you need for a use case or an area? Because then you can say, if I'm doing clinical decision support in that area, that's how I find that data in the record. And even if we standardize on FHIR and SNOMED, there are still loads of different ways of saying the same thing within those. So we need to kind of hone that down so that we can start defining how to find data for a particular use case. Certainly that's kind of the approach we're taking. I'm really interested if other people are taking that approach, defining data sets for diabetes or for other wide use cases. We should really be looking at where do we internationally come to consensus on that, because it's nearly what HL7 does, but I'm not sure it is. It would be great to identify a place where we can do that internationally.
Well, thanks. And Naoki, please respond to this call for action.
Actually, usually physicians use this kind of the guideline, clinical guideline. But in the case we can implement this guideline into the digital health, the patient and the citizen can understand spontaneously this kind of guideline. This is, I think, a really important thing.
Great. And thanks all panelists for this interesting discussion, and especially Naoki, because he's staying up until very early in the morning. So from Japan. And I'd like to hand back to Andreas, our chair of the JIC.
Excellent. Yeah, this concludes today's open forum. I think with the collaborative work presented today of the SDOs, the path has been laid out for more transparency and quality in digital tools. Even as we learned, there's still quite some more room for further harmonization. Now it's important to follow this path, but by carefully also ensuring to build and maintain the trust in such labeling as was presented today. I'd again like to thank all speakers and the organization team of today's Joint Initiative Council Open Forum. Also thanks to the attendees for having joined us. Again, to stay informed about open forum, virtual open forums and the joint activities of the JIC member SDOs in general, follow us on Twitter and on LinkedIn. And please also check out the JIC website, where this recording will be shortly shown up, and also where recordings of past open forums are available. I wish you a pleasant rest of your day, wherever you are and at what time zone you are. Looking forward to virtually see you again in a future open forum. Bye-bye.
Bye. Thank you.
Thanks a lot. Bye.
Thank you.
Bye.